Okay, so thank you, everyone. This is a joint initiative between two hospitals and Eurecat. So there's not much I can tell you about lung cancer because you all know what it is. But what really struck me as a fact is that altogether it kills more people than the next 3 more prevalent cancers. So you can imagine. And also, for most of the cases, it goes unnoticed until it's too late. So the idea of the Deep Lung Initiative is first twofold. First is there's a myriad of chest X-rays that nobody but traumatologists, for example, will look, and they are not informed, and that they go unanalyzed. So the idea was, can we build a classifier so that we can find incidentally masses in those chest X-rays? Then the second objective of the project is more related to diagnostics itself, and is how we can improve the diagnostics of lung cancer, not by just looking at the CT scan, but also taking into consideration the time evolution of the nodules that we have present, because this is actually how radiologists work. And if you look at the state of the art, most of the researchers doing research in CT scans and lung cancer, they miss this information. And last but not least, once we have these nodules, how can we better characterize them and get most information of them so that we can build better models to improve first the detection and also the prognosis of this cancer and even eventually plan for therapy. This project is, as I said before, is an initiative between 2 major hospitals here in Barcelona. One is Consorci Sanitari Parc Taulí for the X-rays pilot that is going to be kicking off early next year. And right now we have finished the whole pre-pilot, so you will see the last bunch of results. And the other one is being validated at Hospital Vall d'Hebron here in Barcelona, which is also a very big hospital here. So before we start detecting masses in an X-ray, you have to take a walk on the dirty side of radiology, because when you want to grab chest X-rays, not only do you have to look at the DICOM file and see whether or not it's a chest X-ray, but in most of the cases, or in some cases, you will find surprises because it says it's a chest X-ray, but you find a leg or an abdomen. So you really have to start by pre-classifying your data. So we have a first classifier and we ask, is it a frontal thorax? And yes or no, because you also have lateral images. And then from there, you can really start your classification problem. And you would be also amazed of the many things that you could find in a human chest, because not only you have the masses, the lungs, and the tissues, but sometimes you have pacemakers, you have stents, you can have all kinds of stuff. And this can also, render or lead your classifier bunkers, and you really have to have some kind of measure or tackle this variability. So, of course, the first classifier is easy. It's just a simple, plain convolutional neural network that gave us an accuracy of 99%. What else? But then when we start classifying nodules, we see something more interesting. And the actual accuracy of the system decreases dramatically. But once again, here the idea is to find incidentally masses in the chest X-rays. But also, if you put to the crunch the radiologist doing the report, you will see that, or you see normally that they not always agree, and that perception is really a fuzzy term, because sometimes you may have a mass that goes unnoticed, and this because not that they don't know what they're doing, it's because it's a very difficult classification task. So here what we have done is we have picked a full, quadrimester, so 4 months of chest X-rays from the hospital. We analyzed about 25,000 X-rays with our server and our algorithm. It was trained with 600 images, so you can imagine the kind of test that we're doing is very wild. So here you see the cumulative density function. Of course, it goes between 0 and 1, and what we did is we presented a sample of 200 images from the higher side, then 400 in the middle and 200 in the lower side, and these are the numbers of positives that were declared by the radiologist. So you see that for the higher end, and when we start doing the pilot, we are going to be presenting those with a higher probability of, well, with a probability of 98% or above. So you see that we have detected above 25 cases that were unnoticed by the system. So already it's performing. And these are people that will benefit from more timely diagnosis. Not only that, we also need to convince the doctors that what we are doing makes some sense. So in order to do that, we not only used a convolutional network, but we also used a region proposal convolutional network that you can really see where the network is placing its attention when it's making a certain classification. So here we have 3 positive cases, and you see that here is where it placed its attention, and the mass was here. In this case, it was here. And in this case, there were 2 here, and I don't know what was going on in the stomach or the bowel. I don't know what this is, but somehow we did a good job. Now, to something different. We are no longer in the realm of the incidental detection of masses. We want to diagnose lung cancer properly. And in order to do that, we are now resorting to the top of the quality of images with CT scans. And first of all, we need to detect the nodules and map them very well, because you can have always lots of false positives and false negatives. We map them because, of course, as I said before, we need to assess the temporal evolution of those nodules. And then we do the assessment. So we either say if it's growing, sometimes this growth is as small as a voxel. So we are giving somehow hyperperception to the doctors doing the diagnosis. Then we also classify their malignancy based on this growth and also on the shape and other attributes of those. And of course, density evaluation, because we have seen not only from an artificial intelligence point of view, but also from a clinical point of view, that density plays an important role in the evolution of lung cancer. I really loved the presentations before. I wish we had access to the tools from our colleagues from T-Systems, because we really struggled to put this together, because we have the databases, you have to curate these databases, you have to analyze the CT scans, you have to annotate them, you have to segment the nodules, and sometimes segmenting a nodule is not as straightforward as one may think. Then we have to, of course, anonymize, curate the data, and store it properly, and create the database that has to be shared by the different researchers. Of course, we also need to get some clinical data, because if you have, you don't want to have your system having a gender bias or an age bias or something like that. And also, it's very important to know whether or not the patient has a background of smoking, or if it's has a prior story of neoplasia, or if the patient passes away, there's no need to actually do more analysis. Of course, we need to have our ground truth as well defined as possible, and with that, we start doing our classification. This is the results that we have so far. I like this. Well, we like this curve, and also it's loved by the radiologists, because it's giving you your accuracy by number of average false positives. So you see that around 2 false positives, you get an accuracy of around 90%, and between 2 and 4, things start to get really, really good. So it's something that is ongoing, and we really want to keep on improving on that. Then regarding the nodule segmentation, here we have a really small nodule that with this unit that we have adapted to the segmentation is doing a nice job. Here is where the issue of segmenting the nodule really gets into play, because sometimes you have the nodule here that it's infiltrating a rib, so how do you segment that? Do we have nodule here or we don't? So here we have our label, and here we have our prediction. So we see that it resembles very well. This is a point blank nodule in the middle of the lung, so you see that it's doing a nice job. So in conclusion, the idea is to validate this project into clinical studies. For the first one, the pilot is going to be starting next year. Now the servers have been commissioned. We have put in production, as of last Friday, the algorithm in the production environment of Hospital Parc Taulí. And we will see how the story unfolds in the next 4 months. So hopefully we will be able to repeat those results. We are pretty confident, but you never know. Then also the big potential lies into the assessment of the temporal evolution of the nodules. We think that it's a real value, but also it imposes an important burden in the way you analyze things, because you have four-dimensional networks. And last but not least, at least we think that we are aligning with the radiology workflow and in the way that radiologists work and do their job, so that we can improve their efficiency and efficacy by leveraging upon the power of AI and deep learning in this case to help them do a better job. So I don't know if you have any questions.
Would the specificity of your AI be improved if you would not have 15,000 but 1 million images to take into your system? Because, yes, of course, in the region you can come to a certain level, but if you all do the same things, it's digital, so you could join up with other initiatives to increase the number of images that you have you thought on this, or are you working on it?
We are working on this, and I absolutely agree, and it's a perfectly valid point. First of all, the system was pre-trained for the CT scans. It was pre-trained with a public repository of images, which is international, is the LIDC repository. Of course, we were asked to, or we need to put this in motion, and we have to be local and start local, but with the idea of expanding, okay? And with that in mind, we have already applied for a project for a European project, Horizon 2020, which is resorting to a European repository of images where we can really assess, in this case, lung cancer metastasis. So we will see. So we are thinking big, but also we need to start small if we want to make things happen. So you always have to find the balance.
Do you have data about accuracy for radiologists to compare your algorithms against it? I think it's the measurement.
We will have it, let me put it this way. Because now we have the results that the radiologists have produced for this. We know the level of agreement, and we need to do the statistical testing between the agreement between each of the 4 radiologists that participated in the panel classifying the nodules. And also we want to see how our classifier stacks with the agreement between the 4. So we have the data, but we have not analyzed it yet. So sorry, but we will have it. And it's going to be interesting for sure.